Thank you all for getting up early and coming to uh, talk about this subject. And so this is a joint presentation with the APSA Ethics Committee, the APSA Wellness Committee, and the CAPS Ethics Committee on exploring surgical goal-oriented care and challenges in the care of patients with trisomy 13 and 18. My name is Sarah King. I'm a research resident at the University of Michigan, and I have several great co-moderators, including Dr. Rito Bartschuger, pediatric surgeon at Dartmouth, and Dr. Katie Rowland, who's a pediatric surgeon at the University of Washington University, St. Louis. And we also have three great panelists in addition. Dr. Ryan Antiel, a pediatric surgeon at Duke. We have Dr. Alexa Robbins, who is a pediatric surgery fellow at Children's Colorado, and Dr. Badr Shakshir at the University of Chicago. And so, just to give a little bit of background for our talk today, trisomy 13 and 18 occur at about 1 in 1,800 births. And before 2000, they were really considered lethal syndromes with a 50% mortality within the first week of life and 95% within the first year. But then in the last 25 years, those survival rates have increased dramatically, with being reported up to 19% overall. And furthermore, in the post-2000 era, the literature has really explored different interventions for that impact the survival of these patients. And so it's been reported that medical intervention alone has shown improvement in 1 week and 1 year survival. One institution found any intervention, whether it was medical or surgical, could improve survival. And Tamaki et al. Found significantly improved survival rates that they specifically attributed to surgical intervention for these patients. Despite the improved survival rates, there's still ongoing controversy in treating them. So trisomy 13 and 18 patients come with a lot of other concerns and considerations outside of survival, including quality of life, parental burdens, health provider burdens, moral distress, and the center-to-center variability in management. And so today we're just going to have a discussion both with our panelists, and we also invite all of you to contribute if you have any comments or questions as we go. And there will be also a poll system throughout the discussion. And so just to kind of get our ethical brains thinking, our first poll question is: you're consulted for a gastrostomy tube placement in a patient with trisomy 13, and would you offer surgery? It should be on your phone. I don't think we can't bring it up. All right. So of 27 answers, 25 said yes, and 2 said no. And what about if you're consulted for a baby with duodenal atresia in the setting of trisomy 18? In that situation, do you offer surgery? Looks like similar distribution. 26 say yes, and 2 say no. So again, we'll circle back to kind of go into that further, but for now I'm going to hand it over to Dr. Rowland.
All right, well, so before we jump into some of these case questions and some of the maybe more controversial case questions, we wanted to just give a quick little primer on some of the ethical issues that we're considering. Recognizing it is a Saturday morning, we're going to kind of dive into a brief ethical discussion. And so for the poll that we just completed, looking at patients who had trisomy in the setting of needing a G-tube placement or duodenal atresia repair, it seems like the majority in the room and who had answered the poll would proceed with surgery, although that was not unanimous. And probably if we had performed the same poll 30 years ago, the answers would have been very different, with maybe a majority of surgeons actually not offering those interventions. And so when we talk about futility or the procedures that we do and the meaning behind them, it's important to recognize that this exists along a continuum. Futility is defined as an intervention that runs counter to the goals of medicine. And so that kind of brings us to ask, what are the goals of medicine? Physicians have a moral obligation to pursue these goals. And while we would all readily recognize that providing a cure is one of those goals, relieving symptoms, improving function, preventing illness or untimely death, avoiding harm, and even easing suffering at the time or near the time of death are goals of our profession. But we have to ask the question, is prolongation of life in and of itself a proper goal of medicine? And who are we as physicians to define what is meaningful life? In fact, it's been shown that physicians tend to underestimate their survival and the quality of life of disabled children, and parents are generally much more positive than providers. Parents are less likely to think that being severely disabled is worse than being dead. So with that information, as we consider what futility means, there's two different ways to look at this term. One is the sense of quantitative futility, a procedure or an intervention that is physiologically ineffective and just won't work. That can be easier for us to define. But this concept of qualitative futility is a little bit more difficult to sometimes grasp. Qualitative utility refers to the normative assessment of the benefits derived from a procedure. So whether an intervention reasonably achieves one of the goals of medicine and provides benefit or value to the patient themselves. Another way or another term that we can use besides qualitative futility is this idea of potentially inappropriate or potentially appropriate or potentially non-beneficial or beneficial care. All of these terms help to capture somewhat of the subjectivity and the sensitivity for families who are having to make these decisions. And we also still provides us with the language that clearly conveys the patient's prognosis and acknowledges the limits that we have in medicine. But futility, even using this terminology, can sometimes be difficult to define. We understand this well as surgeons, right? In an ideal world, we would be looking at a procedure where we know that there is a clear and great benefit to the patient and little gray zone as to whether or not that procedure will be beneficial. But unfortunately, many times we live in a much different situation. And this is a situation we face as care or survival continues to improve, and we have to continually reassess what might be potentially appropriate or potentially inappropriate for a patient. And so as this gray zone expands, it can become more and more difficult to know with certainty that the procedure that we're doing for the patient is beneficial. Dr. Javier is a neonatologist in Montreal, and I think she put this very beautifully when she said that the boundaries between these zones are drawn by physicians who decide whether the outcomes are good enough or bad enough based on their interpretation of the medical literature and their values. Parents take life or death decision with statistics that can be value biased by physicians, both in their creation and in their interpretation. So when we think about goal-oriented care, we really think about providing care for the patients that's informed by the patient's own values and priorities. This type of care is derived from discussion with the families, and it involves eliciting the patient and the family's values and goals, communicating which interventions serve those goals and which do not, and only ultimately offering those interventions whose outcomes are in line with the stated values and goals. When we as physicians fail to be proactive and intentional about having these conversations, there are consequences. And so our patients can receive care that's discoordinate with their goals, and their families can experience confusion about which decisions are theirs to make. Families can feel burdened by the implication of their decisions, and patients can miss out on the opportunity to have a good death and to spend maybe their final hours or days not in pain and with their family alongside of them. Healthcare costs are higher, and it affects us as physicians and our healthcare teams as well. Healthcare teams experience moral distress when we reach communication impasses with families, when we feel disempowered to voice our concerns about the care a patient is providing, and when we're asked to provide sham or unnecessary resuscitation efforts. Before we turn it over to our first panel discussion, I'd like to leave you with just one more quote, which is, ultimately, when parents are listened to and information is provided in a way that is best suited to them, trust is developed and there is less chance of disagreement. Parents should not feel that they disagreed or yielded. Rather, they should feel like good parents who did the best for their child.
So good morning. We'll move to our first case scenario. So we have a term-born infant who is born with trisomy 18 and congenital heart disease. And after birth, you try to pass an orogastric tube, and it coils up in the upper esophagus with distal bowel gas on X-ray, consistent with a TEF with a esophageal atresia, so type C. So do you offer surgical repair in this 12-hour-old baby? And you can, if you want to comment from the audience, or what would you do? And we have people who are practicing in at least 2 continents and 3 countries, so there might be a little different approach there as well, or not. What do you do? If not, we'll have one of our...
What's the extent of the congenital?
Good questions. You might not know by 12 hours. You haven't done an echo yet.
Cannula oxygen. To me, I think that's where the crux of it is.
So let's say it's a parent who had prenatal care. There is no hypoplastic left heart syndrome. It might be potentially a correctable cardiac defect.
I think that, that's like the major thing for starters, right, Brittany? Like 20 years ago, everyone was bucketed in like the same sort of category, where there's obviously enormous spectrum of disease severity. So when you look at case reports, not surprisingly, folks who are diagnosed after birth have longer survival and things like that, right? So there's something about kind of the bias we bring to these discussions when it's known ahead of time. But I think what you're getting at, which we use all the time, whether it's CDH or other anomalies, are we have to figure out how sick this baby is before we can even have conversations about goals. So sometimes we jump over that step. This question is probably purposely ambiguous, but yes, that's the first thing we need to figure out. What sort of severity are we actually dealing with so that we can speak honestly to that family?
I was just going to add 2 things. One, I wanted to highlight what he said about the difference between patients who have a prenatal diagnosis and have had time to consider these options. Whether or not they've considered a esophageal atresia variant or not is more difficult, but if they've had an idea that this will be a complicated pregnancy, I think that those are often easier decisions, and you often get buy-in from the families. But I think here the final question is stated, do you offer surgical repair of the TEF, right? And I think so that's a 2-step question, right? Question 1 is, do you even offer it? And then question 2 is, does the family accept it, right? And I think that, maybe you guys can tell me in the modern era, what situations would you not even present this as an option to the patient?
At our hospital, similar to what other people have said, I'm at the University of Michigan. It all really hinges on the congenital heart disease. And we're really the only hospital in the state that will intervene on trisomy 13 and 18 babies. So they all come to us. And then it really comes down to if the cardiac surgeons are willing to intervene and they're very aggressive, then we have sort of felt like we need to do everything as well, because if they're kind of the final step, and they're a very aggressive group, and they will sort of offer just about everything. So everything else kind of falls in line. If you have the congenital heart surgeons who are willing to do really aggressive procedures, well, I don't really have a choice not to do a G-tube. I don't really have a choice not to do this if they're willing to do all of these other things. So in these situations, we sort of have to figure out the congenital heart disease, see if they're willing to start walking down that line, and then for us, sort of everything else falls falls into place
So let me add 2 layers of complexity then. One, how often do they not give you a definitive answer within the first 24 hours?
all the time.
All the time, right? So I think there's a lot of, well, let's wait and see, like, you know, if the kid survives your procedure, maybe I'll consider it, right? And then the second layer of complexity is, you know, we can discuss later because I think there's a case on it. But I agree with you. All of us want to know what the cardiac surgeon is going to do, but we often don't have that information in this scenario, and so we're still left to decide how we should proceed.
And how do you address the discussion with the family, right? I think it's very important on what you offer and how you discuss that. Yeah. All right. Well, this was just the scenario that we had. So the cardiac surgeon state they believe the child is a candidate for further cardiac surgery, and so we got to some of the answer there. Now the cardiac surgeons say they do not believe the child is a candidate for cardiac surgery. And I think that's where we come into more, sorry. Oh, sorry.
I'll take this one. France, you're at University of Minnesota. We're thankful that Alexa's going to come talk us through this. Well, so we've been in a situation as well. I appreciate you sharing what's happening. I was talking about it in Harvard, but we've actually pushed our cardiac surgeons a little bit on a couple of occasions. So this past year, we had 2 that were like this, and they were born into families from a couple of Somali families. So really hard conversations in general in terms of faith, what's the right thing to do. You know, these things are way above my head, obviously. We actually felt like it was reasonable to help these kids get through the newborn period by preparing this. And we found that you can almost bring the cardiac team to the table. But we've also had a change in cardiac care providers. So there's been a shift in perspective on this. But we have a newer group that is very keen on avoiding the complications that end up in the rankings and such. So they're risk averse, which is understandable. I would say that we've done it. It feels a little uncomfortable because you wonder what's going to happen next. But we've also seen it bring them to the table a little bit. You're suggesting, let's see how it goes. Let's see if your patient survives that operation. Maybe visit them. Another great topic.
And I think it's hard when you have a parent who asks you, you have all the technology to do it. Why can't we try, right?
These things I try to also think about, or instead of thinking about it in series or sequentially, which way to go, what's your next step, what's the end step? I mean, what's the most life-limiting condition for this child at the time point? And are they going to be in the hospital, out of the hospital? What is the end, what's the family vision for the end, you know? Talk to them, and they may not know, and you know, a lot of times we don't. But I think that because, you know, think about, I don't know how big this baby is turning, so assuming it's an operable size, but it's cardiac, you know, it's almost maybe not. Is the family envisions feeding this child? Well, you're going to need to do something to actually repair this stuff, because if you were trying to prevent the child from aspirating and having a event, well, you need to repair this stuff because you can quickly, there's options. You don't have to do the entire operation. We're trying to understand, well, then they won't get the fistula. So there are things that may be less, complete, but may still help and support and secure this child. Find out what the family, and have it, you gotta have a conversation like, well, if we do this, this is what the situation they're going to be in. Won't get to be just try to get a real life picture of what's life after each intervention.
And I think it's the hard question, what's the right thing to do in a state of uncertainty? Just to echo our presidential address yesterday, but I think I wonder what maybe Alexa you have to say on.
Yeah, I think there's, trade-offs in every operative decision-making conversation. And I think it's not just about risk benefit, it's also about the burden that of every operation, the pain and other things that come with what we do to patients. And the purpose of that is to have a long-term or even short-term gain of more time, symptom resolution, better functional status. But what's difficult in this population is the uncertainty of the ultimate gain for the burdens you're putting the patient and the family through. And so I think the first step is to explicitly state that with family. We know with some certainty about what the neurodevelopmental outcome range can be, but the challenging part with these patients is we don't know how long they may have or what the potential benefit is, especially in a situation where there's also this significant cardiac disease burden. So I think trying to make sure that the family has a good understanding of what the true benefit is and the true objective of the procedure before you're talking about the burdens, because if you're expecting that your child is going to be able to eat normally, and that's the purpose of the operation and what they're willing to go through for the chance of that, when actually we don't think that that's something that's going to be achievable, I think is your first step in these conversations.
Yeah, and I would love to hear actually people's experience on this, but I've considered those kind of what I would call in-between surgical palliative options before in these scenarios. And I find, maybe I'm terrible at speaking to families, but it's really hard to convince them of this, right? They have a vision of what they want. The decision isn't per se a rational decision, but an emotional decision, understandably so, right? And you can't oppose those perfectly, but they certainly sit on a spectrum. And I think it's very hard for somebody to accept, okay, you're going to prolong my baby's life, which may last days or may last, likely months, potentially years. But you're going to do something non-definitive that has relatively high risk. And I haven't found many people to buy those type of scenarios, but I'd love to hear situations in which you've seen it. I also think they're very difficult to counsel, right? Because by the time you get through all the information of, your child has trisomy 13, congenital heart disease, they're not an option for that. It's likely a type C fistula. Here's what the clip falling off looks like. Here's what an anastomotic complication looks like. By the way, we could get rid of the anastomotic complication issue. Your kid would never eat, but the clip could still fall off, et cetera, et cetera. It becomes, a very lengthy conversation.
I think to echo what we feel is success, right? We want to cure a baby, and in this situation, it's not possible long term. I think it probably reflects what we struggle with on our own side. And I would just echo Dr. Janvier's, there's an editorial that she wrote, I think 20 years ago about pepperoni pizza. If you haven't read it, it's worthwhile reading it, about what success means to physicians compared to families' decision-making processes. So any other comments or questions on this case? Yeah.
I sort of have a question. This is really confusing for families to understand. We're talking about things like clipping, ligating, going inside the belly, putting a vessel around the esophagus, putting a J-tube in. Do we try to put? So I was wondering, one of the things I've learned from our palliative care team is this concept of palliative paternalism, where you're not saying we could do this, we could do this, or we could do this, now choose. You're kind of helping them, asking them what do they want for their child and what their goals are for their child, and then kind of giving them a direction. I don't know, maybe Alexa could talk a little bit more about that. I think it's a really preferable way to do it because it's very confusing for families to understand, all these different options.
There was a nice study out of Philadelphia, some colleagues of mine, Steve Jaffe, Elliot Wise, they didn't look at surgical patients, but in the neonatal intensive care unit there, they tried to differentiate, like, did parents want to be involved with the minutia? Because there was a perception that the good neonatologist would go through everything with the parents and it'd be true shared decision-making. And they did a really elegant qualitative study, and they had some neat methods from behavioral science. The finding, in brief, was basically like, parents don't want that. They trust us to make those sort of decisions, and that intuitively makes sense. None of us get permission from families about, the operative technique we're going to use, or the suture, or how we, get in the belly laparoscopically, right? Like, that's just assumed that you're bringing that sort of expertise. So in these gray zones, I think you're exactly right. It becomes uncomfortable when two families with children with the same diagnosis choose very different things, and we become, very hands-off, which actually kind of, I think, burdens the families in some way, as opposed to carrying some of those decisions ourselves. So that's a really interesting question. If we understand their goal, does the pendulum swing back a little bit? Ought we be more paternalistic than we might otherwise feel comfortable? I think that's an important question.
Yeah, Gretchen Schwarze has some great work about this in terms of thinking about our role is we are taught in medical school to be educators, first and foremost, and then think about consent from like a medical legal perspective of needing to lay out all of the options to make sure people feel informed. But it's actually, we're never going to bridge that information gap. There's no way in a patient with this complex, you're really ever even to another physician family going to get them to the same level of all of the experiences that we've had. And so part of it, I think, is to make sure people feel informed, but to get to know the families and what matters to them, and then help them navigate the trade-offs of the risk, benefits, and burdens of each of these interventions. And so making sure that we spend time in the beginning of the meeting rather than trying to bridge that information gap to try to get a sense of what matters most and what's important to these families. And then I think that's hard, right? Like, how do you have that conversation? How do you figure out what a patient's goals are other than walking into the room and saying, what are your goals, right? Like, that's difficult. So some of the things that I ask, are when you're thinking about your baby's future, what are you most worried about? What are you hoping for? What have the doctors explained to you about what your baby's future might look like? And because the answers to that can be, I'm really worried that my baby's going to experience a lot of pain with no benefit, or I'm really worried that my baby's going to die in this operation and I won't be able to say goodbye. I'm really worried that my child will die without us having as much time as possible with them, no matter what that looks like, as long as they're not suffering. And so I think trying to get a sense of what is going through their mind, and then you can tailor your recommendations to that. Because some of this too is like aligning the language that you're using. We talked about having conversations about futility or life-limiting illness or a lethal diagnosis, some of these things that can be really triggering for families that are very much on the spectrum of wanting to do as much as possible. But for other families who are choosing to do less, you can align with them in a better way by saying, many loving families choose to not pursue some of these interventions because they feel like the burdens outweigh the potential benefits here. And so based on what I'm hearing for you, my recommendation is that we do this. And I really feel like it's an obligation for us to make a recommendation. And then I'll usually say afterwards, well, how does that land? Like, if I really feel strongly we should do this, but if when you hear me say that, your initial reaction is like, oh, I'm not ready to stop yet, I'm not ready to dial it back, then it's at least a way to kind of get a sense of that, rather than just saying, here's all the things that we can do in the context of this complex disease that I've spent 20 minutes drawing pictures for you. Now, like, what do you want to do? I think that's really difficult for families.
I was just going to briefly add, Lauren, sorry, I know it's hard to hear over there, but I was talking about two cases that we had in Minnesota where similar situations, some ambiguity with the cardiac surgeons, and it creates a lot of, it was challenging within the group because the two surgeons felt differently about what to do, and the NICU created this, not they didn't create, but there was this challenging juxtaposed between two families who knew about each other in the unit, and what do you do with that? So this is really helpful to sort it out, Alexa.
Hi, Brittany Grayson from Kenya. So, I have found that I live in a much simpler and practice in a much simpler society where there's no prenatal diagnosis and there's no cardiac surgery. And so some of these decisions are made for our patients. But I think, the tenets that I learned about palliative care training in the US are the same. And unfortunately, like the question that we ask these parents is essentially not in this way, but like, how do you want your child to die? And I think when we think about, even an older child or an adult, you have a sense of their personality, the families can offer something like that. And so I guess I just wonder, like, how would the panel advise walking a family through that decision when, like, they don't know this human, the human doesn't have a personality, but it's still like you can get to know who the parents are. But like, are there better questions that we can be asking in our setting to get the answer to that, and then tailor our recommendations to meet the end of life, the where do you want your baby to die question.
Yeah, there's a lot of easy ways. They take like 3 points and the conversation takes about 2 minutes. This has been written about extensively, right? Like, I think the first thing is to investigate where the families are. I think these kind of reflective questions that Alexa has discussed about, where does that, I recommend this, where does that land with you, and kind of using that as a branching point. But I really think that initial assessment of where the family is and their understanding of the process and their desires, and then painting them a picture, in the adult surgery, they talk about best case, worst case, but you paint them a picture of, well, the average case like this, we do this, and they spend 3 months in the ICU. Some small percentage go home for a short time. They usually come back to the hospital. In the case of a purely palliative change in the goals of care, we would wait for family to be around. We would make your child very comfortable. We would make some memories. And then there's pathways in between. And I think, obviously not that quickly, but you kind of paint a picture not of the options, but the landscapes and the storylines. I think it becomes very difficult because all of us know there's so much variability there, but certainly painting the extremes and the likelihoods of the extremes, I think, is relatively understandable compared to the way that we usually do things when people agree with us or the indications are clear.
We'll move to our second case.
Okay, our second case this morning is a 6-month-old with trisomy 18 who's found to have a large right-sided liver mass and an elevated AFP, consistent with a hepatoblastoma. On imaging, the mass appears resectable with adequate margins via right hemihepatectomy. There's no evidence of metastatic disease on your workup. Do you offer surgical resection? It's there in the app, but just by a raise of hands here in the room, who's going to offer surgical resection for this baby? Yeah, that's what we saw in the app, is the majority of people said that yes, they would offer a surgical resection. But what about if we add a little bit more complexity to that, and now on imaging, this child actually has evidence of diffuse bilateral lung metastases? Does that change anybody's mind in how they're going to approach this case? Dr. Antiel, how do you think through weighing the uncertainty of two, significant disease conditions? So, here we have a trisomy with, a survival of 20% at a year, although this child has already made it out to 6 months, who now has, a hepatoblastoma with a metastatic hepatoblastoma as well. And uncertainty in both, because with chemotherapy and surgical resection, actually, our survival, even in the setting of metastatic hepatoblastoma, has certainly improved.
Exactly. I think in this scenario, the shift, right, from the non-metastatic to metastatic disease, I think is really just trying to add that layer of complexity around the burden of care. Not that major liver resection is not burdensome, especially for a patient with trisomy. But now there's going to be the ongoing therapy as well. And so I can imagine a lot of families, again, if you're offering, we can do the resection, and we think that's probably curative, and here's our percentages, versus, okay, we're going to do that resection, and now we're going to start neoadjuvant or adjuvant chemotherapy. At what point does, again, the perceived burden of this just become overwhelming to the family? Or are there the families who say, those numbers seem all right? And obviously we have a smaller experience with this, but I know the folks in Denver have published on this. The results aren't terrible. So now we're kind of in that gray zone as far as what we offer them. So again, I think this creates, this scenario creates a huge conundrum, I think, for the families, because now that prolonged burden of care is more of a question as they're trying to think through survival versus how they want their child to die. Alexa, I'm curious your thoughts just with your group in Denver and what you guys have found in these scenarios.
Yeah, so the paper out of Denver is looking at all of the case series of everything that's been published more than it's been, we have a large experience with this, but I think that what's coming to mind in thinking about this case to me is this concept of surgical buy-in, this idea that once you start an operation, you are signing up not just for the operation, but everything that comes after. And I think the palliative care docs in some ways will come in and say, let's do something like a time-limited trial, right? When you're thinking about our child in the ICU in the beginning of life, like, okay, let's have this conversation and see how you're feeling about things, but let's come back to this in 2 days when you've never been a parent before and all of a sudden you have this baby and how do I want my baby to die? I don't know how I feel about any of this. I've never had any lived experience of this moment. So let's come back to it once we've had a day or two to think through this and figure it out. And I think with a child who's going to go through a major operation and then chemotherapy, and we think about it as being this, okay, you're going to have this conversation, we're going to jump in because to get the full benefit, we have to do all of these things together. But maybe you say, yes, that is true, and we're going to do this operation, and then we're going to come together in a month, and we're going to see where things are at with chemo, and we're going to reassess. And therefore, it doesn't have to be one decision right now. It can be, let's come back to weighing the risk, benefits, and burdens at X time once you've had some experience of what it's like to be an oncology patient. And then describing the natural history of, like Badr was mentioning, like a story of what does life look like if you don't pursue therapy. And, so sometimes it can also be helpful to engage in these conversations with your colleagues there from palliative or oncology to talk through I can talk to you about what surgery looks like, but I'm not around as much for what happens when we don't do things. So how do we paint that picture together?
Those are all great points. If we try and make this case even a little bit more ethically challenging, imagine still a 6-month baby with trisomy 18, but this time at the time of presentation, the child has extensive disease throughout their entire liver, pretext 4. No evidence of metastatic disease, but despite chemotherapy, the mass continues to really involve all 4 sections of the liver and is not amenable to even what would be considered a very aggressive resection. Would you offer a living donor transplantation to this patient?
Dr. Healy.
Dr. Shakshir, what do you think?
This was the point I was going to make to Dr. Arnold's point. Is like the cardiac surgeons will say, yeah, let's see how things go. Or we'll do the initial step, but this may need transplant and we're going to have to see how it goes, right? And so I think it's very, very difficult to offer therapies when the definitive therapy is not available.
Transplant is not, I've been told that trisomy 13 and 18 are not transplant candidates. Is that true? I mean, obviously the pendulum the needle is moving.
I think that at most, go ahead. If someone.
as a transplant surgeon, you also feel liver donated, liver grafts are a scarce resource. And if someone has an expected their life expectancy of a year, then a liver is coming from a community that is not going to have a survival of more than 1 year. So stewardship or management or factor in that. And then if you have a living donor, you're actually having a totally healthy person at risk for death, significant complications, donate for the benefit of another patient. But that will not really have that long of a graft survival. So it gets really complicated. You may get a different, in Colorado, you mentioned Denver, I mean, they have great liver transplant program. So that part of it, you think, okay, it's going to be safe. And it should happen, we can do this, it's still, those other considerations are still there. And I do think that probably most programs would probably decide not to offer. I don't know what everyone, for this diagnosis, because the overall life expectancy is so short.
But getting longer, right? So at what point is it tip, right? I mean, I have 6 and 7-year-olds who come to my clinic for their G2 changes, right?
Right,
So-
and that's where you make it tough. It's like with trisomy 18 mosaicism, right? And what's the degree of mosaic? Like all of us have seen these patients, these kind of walk the tweener line patients, right? I think the question though to go back is let's look at kind of the 3 therapies or 2 therapies we've discussed and a third one and our willingness to offer. So transplant, like you said, is a special field because there's actually a finite resource. In this case, we were trying to take the finite resource away because there's a living donor willing to undergo it. So it's really just the risk. But I would venture to say that all of us feel more comfortable saying a patient is not a candidate for ECMO or ECLS as opposed to not a candidate for a TEF repair, right? I mean,
Not in Michigan.
Go ahead, please. I would say across the nation that's likely true, but perhaps it's not.
Looking at Sarah. I was gonna ask about
Yeah.
ECMO. I think in Michigan they probably get cannulated. I don't know if we have yet.
Oh, I'm not talking about cannulating or not cannulating this child. I'm saying the step before having the shared decision making is, do you offer a therapy, right? And so I think that for us to like go into the NICU, see some sick kid and say, oh, they're not an ECMO candidate, we feel much more comfortable with that than going in, seeing a sick kid with a TF and being like, they're not a TEF repair candidate. And the question is why? Like if you're looking in this situation where the expected outcome and the expected survival are likely the same based on the data we have, why do we feel like, the polls showed like 95% of us would do the TEF repair, and yet when I brought up ECMO, we didn't take a vote, but my guess is a lot less of us would feel comfortable putting this child on ECMO.
And I think some of the difficulties is also the urgency of the decision-making process, right? So for ECMO, it's pretty quick. For a TF, you have a couple hours. For this decision, you have days. So I think you can involve the palliative care team and the oncology team. And I think I would struggle if we have a mom that tells you, oh, but I'm totally willing to give my left lobe to my child, and I know you can do it. Why don't you offer it to me, right? And I think it's where do you draw the line? And again, for a cadaveric liver transplant, I think your point is very well taken. You have people die on wait lists that have potential to survive longer, but we have the technology again to help there. And how do you actually address that question, and how do you answer that? And I think there's also potential conflict, because if we don't do it here, but maybe they'll do it down the road, right? And so I think that adds another complexity to it. And I don't know, in Canada, would you offer it?
A transplant?
Yeah, a living donor.
A living donor? I don't think so.
Okay, because I know it.
Just because You have stewardship of the medical system, and I'm not sure that most transplant centers would be willing to spend that.
The resource utilization.
Resources on a child who has got long lifespan, while you can offer that resources to a child who has potential.
That's the ethical question.
I was going to add just one facet to this. How many people have experience with the Trisomy 18 Facebook group? Are you a Trisomy 18 friendly provider on the Facebook group? Do you know?
Well, I just look at it every once in a while.
Oh, you can get into it.
Well, we have a very aggressive ENT surgeon. And so every once in a while, I just kind of look at it just to kind of see, also because we're an outlier in the state. So we just get a lot of patients who come from very far away. So I just like to sort of look at it just to kind of see what's going on.
I've never actually been in the group. I've just had families come and say multiple times, you know, this is a Trisomy 18 friendly institution, or we know you're a Trisomy 18 friendly surgeon that you would do it, and that's why we came here, right? So I would say the other facet of this is that some of this, you know, these questions or care is going to be directed towards centers that are rumored to be or known to be Trisomy 18 friendly, and that adds a little wrinkle. And similar to the liver transplant question, I think if anybody is doing a living donor liver transplant for hepatoblastoma and Trisomy 18, expect to see more patients.
Consideration of this. Just as you described, but intervention, intervention is good outcome. So from this intervention, if you're not offered that, you're already like, so by not offering it, well, they're not going to live as long as they would if they get the best outcome from whatever intervention. Proposed. That problem is either accelerate the process. So there's that also consideration. It's not offered.
We have time for one last comment.
Okay, I know you're getting close. Thank you. Megan, I'll stand with you on that. We had the same conversation about one of our complex kids, and we established some criteria because there was a lot of debate. And the cardiac surgeon ultimately said, if I can't offer ECMO as an adjunct to what I'm going to try to do, then I'm not going to do this. And so we tried to set up some criteria so we can add that if this, then this, but with some goals to try to get there sooner than later. Anyway, sorry.
Are those institutional criteria or individual physician criteria?
That's a great question. It was a conglomerate of people getting together to try to create institutional criteria. Yeah, that's the ultimate goal. Yeah.
This has brought up some great discussion this morning and hit on really many of the points that we wanted to raise as to why the care of these children can be challenging and complex within our institutions. Just a few practical takeaways. One, there were no right or wrong answers for any of these cases. But hopefully you felt like the discussion here left you with some things to take away out of this session. In terms of approaching goal-oriented care, it's really important that we define futility in light of the patient and the family's goals and values, and that we focus on the outcomes that are desired rather than the interventions necessarily that we're going to perform. That we're proactive in our communication with families, that we frame palliative measures affirmatively, and that we're very transparent about what the limits of medicine are and what we can offer and do. All right. Thank you guys for participating with us this morning.